This podcast is brought to you by the Prussian blue stain. Watch in silent awe as this unassuming chemical potion is applied to a slide, transforming the invisible world of cellular anomalies into a vibrant, undeniable spectacle. It doesn't just stain, it performs an instantaneous act of molecular alchemy, compelling every speck of non-heme iron to shine with a brilliant, luminous blue, revealing secrets that no ordinary stain could ever hope to uncover.
Welcome back to The Deep Dive, the podcast where we connect the dots from the molecular pathway to the instrument printout.
In our last few episodes, we've been systematically working our way through the differential diagnosis of microcytic anemia. We've tackled the heavy hitters, the undisputed champion, iron deficiency anemia, its tricky impersonator, anemia of chronic disease, and the genetically complex world of the thalassemias.
That's right. We've covered the anemias of not enough iron and the anemias of not enough globin chains, but today, we're diving into another unusual member of this group. It's the one where the body has plenty of iron, but it just can't use it. We're talking about sideroblastic anemia.
I like to think of sideroblastic anemia as the iron utilization disorder. If IDA is an empty warehouse and thalassemia is a factory with the wrong blueprint for the car body, sideroblastic anemia is a factory with a full warehouse of steel, but the assembly line is broken. The raw materials are there, but they can't be put together.
That's a perfect analogy. And just like with our other topics, our goal is to understand the why. Why is the iron panel so bizarrely different from IDA? Why do we see a dimorphic population on the smear? And what exactly is a ringed sideroblast, the cell that gives this entire category of anemia its name?
That's right. So our plan is to first unpack the fundamental pathophysiology, the specific breakdown in the heme synthesis pathway. Then we'll explore the different causes, because this isn't just one disease, it's a whole group of them, both hereditary and acquired. And finally, we'll walk it through the lab, from the CBC and smear all the way to the gold standard test, the bone marrow examination.
Let's get started. To understand what goes wrong in sideroblastic anemia, we have to revisit the very last steps of hemoglobin production inside a developing red blood cell, the erythroblast. The goal is to build a heme molecule.
Right. The heme molecule is like a cage, a protoporphyrin 9 ring with a single atom of ferrous iron, Fe2+, captured right in the center. The entire incredibly complex heme synthesis pathway is designed to build that cage and then shove the iron into it. In sideroblastic anemia, the problem lies in that final step. The erythroblast successfully gets iron into its mitochondria, the cell's power plants, and also the location of the final steps of heme synthesis. But once the iron is in the mitochondria, it gets stuck.
It's a traffic jam at the molecular level. The final enzyme in the pathway, ferrochelatase, is supposed to insert the iron into the protoporphyrin ring. In sideroblastic anemia, something is disrupting this process. Either the enzymes themselves are faulty, or a crucial cofactor is missing, or the protoporphyrin cage isn't being made correctly. The result is the same. Iron pours into the mitochondria, but can't be incorporated into heme.
And what happens to all that trapped iron? It just accumulates. It precipitates inside the mitochondria as iron deposits called ferric micelles. And because the mitochondria in an erythroblast are conveniently arranged in a ring around the nucleus, you get this stunningly pathological, but diagnostically beautiful picture. The iron-loaded mitochondria form a literal ring around the erythroblast's nucleus.
And that is the ringed sideroblast. It is the absolute hallmark of this disease, but you can't see it on a standard right Gamesa stain. To see this, you need a special iron stain, the Prussian blue stain. When a laboratory scientist performs a Prussian blue stain on a bone marrow aspirate smear, these deposits light up as brilliant blue granules. Seeing that distinct perinuclear ring of blue dots is the aha moment in diagnosing sideroblastic anemia.
It's one of the most striking microscopic findings in all of hematology. But the pathology doesn't stop there. These cells loaded with toxic, unused iron and unable to make hemoglobin properly are deeply dysfunctional. They are recognized by the body as defective, and most of them undergo apoptosis, programmed death, right there in the bone marrow before they ever have a chance to mature and be released. We call this ineffective erythropoiesis.
And this creates a dangerous paradox for the body. The brain sees the anemia in the peripheral blood and screams for more red cells. The bone marrow responds by ramping up production, becoming hypercellular with red cell precursors, but because of the defect, most of those precursors die off. So you have a furiously working factory with almost nothing coming out the other end. Even worse, the body misinterprets the anemia as a signal that it needs more iron, so it keeps absorbing iron from the gut, leading to a state of
And this
systemic
creates a
iron
dangerous
overload.
paradox for the body. The brain sees the anemia in the peripheral blood and screams for more red cells. The bone marrow responds by ramping up production, becoming hypercellular with red cell precursors. But because of the defect, most of those precursors die off. So you have a furiously working factory with almost nothing coming out the other end. Even worse, the body misinterprets the anemia as a signal that it needs more iron, so it keeps absorbing iron from the gut, leading to a state of systemic iron overload.
So you end up with a patient who is anemic, but whose body is dangerously overloaded with iron. It's the complete opposite of what you'd intuitively expect. Now that we have the core pathology down, a heme synthesis defect leading to ringed sideroblasts, ineffective erythropoiesis, and iron overload, let's talk about the causes.
As we said, it's not one single disease. Broadly, we split them into two camps, hereditary and acquired. The hereditary forms are rarer. The classic textbook example is X-linked sideroblastic anemia, or XLSA. As the name implies, it's an X-linked disorder, so you primarily see it in males. It's caused by a mutation in the ALAS2 gene.
The ALAS2 gene codes for the very first enzyme in the erythroid-specific heme synthesis pathway. So in XLSA, the problem is that you can't even get the process started correctly. It's a defect right at the beginning of the assembly line. There are other, much rarer autosomal recessive forms, but XLSA is the main hereditary one to know.
But in the real world of the clinical laboratory, we are far more likely to encounter the acquired forms of sideroblastic anemia. These are much more common, and we can split them again into reversible and irreversible causes.
Let's start with the reversible causes, because this is where a sharp laboratory scientist and clinician can really make a difference. The number one reversible cause is alcohol abuse. Alcohol is directly toxic to mitochondria, and it also interferes with the metabolism of vitamin B6, pyridoxine.
And why is vitamin B6 so important? It's the essential cofactor for that same ALAS2 enzyme we just talked about. No B6, no functioning ALAS2, no heme synthesis. The good news is, if the patient stops drinking, the sideroblastic changes in the marrow can resolve within a week or two.
Then there's lead poisoning. Lead is a notorious enzyme inhibitor, and it wreaks havoc on the heme synthesis pathway by knocking out several key enzymes, including furochelatase. While less common now with unleaded gasoline, it's still something to consider in certain environmental or occupational exposures.
Then you have drugs. The classic one to remember is isoniazid, a frontline drug for treating tuberculosis. Like alcohol, it works by interfering with vitamin B6 metabolism. Others include the antibiotic chloramphenicol and, more recently, linezolid. Finally, certain nutritional deficiencies, especially copper deficiency, can cause a reversible sideroblastic anemia. Copper is essential for iron transport and utilization.
So that's the reversible list: alcohol, lead, certain drugs, and copper deficiency. But the more common and more ominous cause of acquired sideroblastic anemia is when it's part of an irreversible clonal disorder of the bone marrow. We're talking about myelodysplastic syndromes, or MDS.
Absolutely. Sideroblastic anemia is a cardinal feature of a specific subset of MDS. In the past, we called it refractory anemia with ringed sideroblasts, or RARS.
The new classification calls it MDS with ringed sideroblasts, or MDS-RS. This is a pre-leukemic condition, a clonal hematopoietic stem cell disorder. In these cases, a mutation has occurred in a stem cell, and all of its progeny have this defect in heme synthesis.
In the last decade, we've made huge strides in understanding the genetics here. A huge percentage of MDS-RS cases are driven by a mutation in a gene called SF3B1. This gene is involved in RNA splicing, and for reasons that are still being worked out, mutations in it lead to the sideroblastic phenotype. Finding an SF3B1 mutation is now a key part of the workup for MDS. For the laboratory scientist, seeing ringed sideroblasts should immediately raise the flag for a possible underlying MDS.
Okay, that's a solid breakdown of the pathophysiology and the causes. Now for the main event. Let's bring this to the bench. A sample from a patient with sideroblastic anemia arrives in the lab. What are the clues? Let's start with the CBC.
The CBC can be very tricky, and that's the first pearl. The anemia can be mild to severe, but the MCV is all over the place. It can be low, making it microcytic. It can be normal, or it can even be high, making it macrocytic, especially if it's part of an MDS. So you can't rely on the MCV alone. But the most important index on the CBC is the RDW.
The red cell distribution width. In sideroblastic anemia, the RDW is almost always significantly increased. And the reason is fascinating. In many cases, especially in acquired forms, you have two distinct populations of red cells circulating at the same time. A normal population of cells produced by healthy clones, and a population of hypochromic, often microcytic cells produced by the defective sideroblastic clone.
This is called a dimorphic red cell population. Your automated analyzer sees this mixture of small, pale cells and normal-sized cells and calculates a very high RDW. If you look at the red cell histogram, you might even see two distinct peaks, or at least a very broad shifted curve. A high RDW with a variable MCV is a big clue.
So you, the laboratory scientist, see this weird CBC result, and you smartly decide to make a slide for a peripheral smear review. What do you see under the scope?
You see that dimorphism with your own eyes. It's a very striking picture. You'll have normal-looking red cells mixed in with these pale, hypochromic cells. It's this dual population that confirms what the RDW was telling you. Then you have to hunt for specific inclusions.
And the key inclusion is Pappenheimer bodies. Pappenheimer bodies are siderotic granules, those same iron deposits that we find in the marrow, that are visible on a white Giemsa stain. They usually appear as small, irregular purple-blue dots, often clustered near the periphery of the red cell. Finding Pappenheimer bodies is a hugely important clue pointing towards iron overload, and specifically sideroblastic anemia.
You might also see coarse basophilic stippling, which is classically associated with lead poisoning, as the lead causes ribosomes to clump together. But the key findings on the smear are the dimorphic picture and the presence of Pappenheimer bodies. Okay, so the CBC and smear are highly suggestive. What about the Reddit count?
The marrow is working overtime, so you might expect a high Reddit count, but you'd be wrong. Because of that massive ineffective erythropoiesis, the Reddit count is low, or at best inappropriately normal, for the degree of anemia. The factory is on, but nothing is shipping. If you calculate a reticulocyte production index, the RPI, it will be low, indicating a production defect.
Fantastic. CBC, smear, and Reddix are all pointing to a strange production problem involving iron. Now for the definitive biochemical confirmation, we move to the iron panel. And this is where sideroblastic anemia truly distinguishes itself from IDA.
Let's walk through it. First, serum iron. In IDA, it's low. In sideroblastic anemia, the body is flooded with iron it can't use, so the serum iron is high.
Next, total iron binding capacity, or TIBC, which is a measure of transferrin. In IDA, the liver makes extra transferrin to scavenge for iron, so the TIBC is high. In sideroblastic anemia, the body is drowning in iron. It has no incentive to make more transferrin, so the TIBC is typically normal or low.
Now for the transferrin saturation, the percent SAT. That's serum iron divided by TIBC. If your numerator, iron, is high and your denominator, TIBC, is low or normal, your resulting percentage is going to be extremely high, often over 60, 70, or even 80%. The transferrin taxis are almost all full.
Finally, the single most important test to differentiate it from IDA, serum ferritin. Ferritin reflects total body iron stores. In IDA, the stores are empty, so ferritin is low. In sideroblastic anemia, because of the ineffective erythropoiesis and increased gut absorption, the body's iron stores are massively expanded. The serum ferritin is very high.
Let's put that all together, because the pattern is unmistakable and the complete opposite of IDA. The classic iron panel for sideroblastic anemia is high serum iron, normal or low TIBC, very high transferrin saturation, very high ferritin.
Seeing that panel should make sideroblastic anemia jump to the top of your differential list. You've effectively ruled out IDA. It also helps distinguish from anemia of chronic disease, where you might see a high ferritin, but the serum iron and saturation would be low because hepcidin is trapping all the iron away.
So we have a mountain of evidence from the peripheral blood and the chemistry. The final step for a definitive diagnosis is the bone marrow examination. This is where we confirm everything we've suspected. The aspirate will typically show a hypercellular marrow with erythroid hyperplasia. It's packed with developing red cells.
And then comes the money shot, the Prussian blue iron stain. The heme pathologist or a senior laboratory scientist will examine that bone marrow slide, and they are looking for one thing: ringed sideroblasts. The diagnostic criterion is typically finding that more than 15% of the erythroblasts in the marrow are ringed sideroblasts. Seeing that perinuclear ring of blue iron granules clinches the diagnosis.
It's a beautiful cascade of laboratory investigation. The CBC provides the first hint with the high RDW. The smear confirms the dimorphic population in Pappenheimer bodies. The iron panel reveals the state of iron overload. And the bone marrow provides the definitive morphological proof.
It really highlights the comprehensive role of the lab. A quick word on treatment, just to close the loop. For reversible causes, you remove the offender, stop the alcohol, chelate the lead, replace the copper. For the hereditary forms, a trial of high-dose vitamin B6 is often given, as some patients with XLSA can respond. For the severe cases and the MDS-related forms, it's often supportive care with blood transfusions.
And with transfusions comes the critical need to manage the iron overload. These patients need iron chelation therapy to pull the excess iron out of their bodies and prevent organ damage, particularly to the liver and heart. And there are newer drugs like luspatercept, which are showing promise specifically for patients with MDS with ringed sideroblasts.
So to bring it all home, sideroblastic anemia is the microcytic anemia of iron utilization. It's not about deficiency or globin chains. It's about a broken assembly line at heme. Remember the key lab clues: a high RDW with a dimorphic smear, Pappenheimer bodies, a classic iron overload panel with high ferritin and high saturation, and finally, the confirmatory ringed sideroblasts in the bone marrow.
It's a fascinating disease that really tests your diagnostic skills and your ability to integrate data from every section of the lab.
It really does. You know, we've spent this whole episode talking about a metabolic bottleneck at the very end of the heme synthesis pathway. It makes you wonder what happens when the defects are in other parts of that same long pathway. That leads us directly into the weird and wonderful world of the porphyrias.
A perfect setup. That's a deep dive for another day. Join us next time on The Deep Dive as we explore the fascinating, complex, and sometimes bizarre clinical and laboratory world of the porphyrias.